My name is Teddy. Just want to thank the organizers for having me. I'm going to talk about acute telestroke and TeleRounding services, our experience at UT Houston. I have no disclosures. Briefly, I'm kind of trying to run through some of these slides. I know we're kind of running late. Talk about the benefits of telemedicine technology, how it could benefit our providers like myself and patients, review the nuts and bolts, some keys to success in telerounding, and discuss the future of teleneurology. Why it's important, I think we've all gone through these numbers, so I won't go through them, but I think importantly for our patients, we all know that TPA is still somewhat underutilized, can definitely be better, and for the purpose of our audience here, access to intra-arterial thrombectomy is really key, and I think telemedicine, teleneurology can definitely open access to that. There's a lot of disparity out there. We know that if you present to a rural hospital, your chances of getting lytics are much less. And obviously that also bleeds into our potential IA patients with large vessel occlusions. So how do we do it? It seems pretty easy, right? We have a whole bunch of neurologists, we get some cameras and technology, you have good internet and it should all work out, but we all understand, setting up a network is really not that simple, although this is definitely necessary. Some questions is, what type of neurologists are you going to use? General neurologists? Are you going to use stroke neurologists? Are you going to use, residents, fellows, et cetera? The technology, a whole bunch of platforms out there, all provide relatively good audio, video access to our patients, and as long as you have good broadband access to PACS and an EMR, you should be ready to go. For what we do in our network, we do use InTouch telemedicine provider. It's relatively easy to use, and that kind of goes into when we talk about telerounding. The technology does matter somewhat because of the mobility of moving throughout the hospital. It's very easy to use. It's continuously being monitored. It's relatively reliable for us, and has worked out really well for us on the floors when we do the telerounding. A lot of telestroke models and teleneurology networks out there. We have ourselves a hubs and spokes, so we have multiple hubs and a lot of spokes. I would, personal bias, think that's probably the best network out there, or the model, because we get to bring our patients to ourselves. We know how our hubs work. We know our local spokes, and we have relatively invested in our region. And we know that the politics in the local area. The other networks out there are going to be our third party or doc in a box when physicians don't necessarily reside in that local area, and they're sending patients from the spoke to a tertiary hospital that may or may not have good relationships with a third party consultant. Our program was set up after I finished fellowship in 2009-ish. Our overall goal was to obviously improve the care in that region, and to solidify or refer hospitals. For those that may know the Texas Medical Center, we had four, I guess at that time there was no comprehensive stroke centers, but we have 4 large hospitals within a 2-mile block, and we were definitely competing for patients, especially through research. And it was set up at that point that using teleneurology and telemedicine was a great way to solidify our footprint and our referral patterns. Our initial goal was to avoid unnecessary transfer, to try to keep the patients locally, because we were getting slammed with patients that are hitting our door that don't necessarily need to come in. And I'll kind of talk about how that kind of flipped as we grew our program. We provide a lot of education regarding protocols, up-to-date research, best evidence practice, et cetera. And I do think that we have served a lot of patients with a lot of benefits in their families. What we do right now, we provide 24/7 acute neurological consultative services. I know there's a lot of networks out there that just respond to strokes. Our spokes didn't want that. They needed somebody to call for that acute status or other issues. So we cover all acute neurologies on the floor or in the ER. We're very, very flexible. Some hospitals have neurologists on the ground during the day, so we would cover during the night. Some have it Monday through Friday and out on weekends, and we'll cover whenever we need to cover. Patients that we typically take care of are obviously potential lytic candidates and IAT candidates. We do help expedite transfers, so we actually pre-accept our patients that we see on telemedicine, call our own transfer center. We send our helicopters if needed. As we grew, and like most networks out there, it seems like we deliver acute stroke coverage. But what happens is that when I talked about we wanted to not take their patients and they actually wanted to keep their patients, this kind of evolved to them wanting to say, hey, we gave TPA to these patients, but we want to keep them. How do we do that? We still have no neurologist. And if we keep sending it to you, our patients aren't very happy. They don't need endovascular therapy, they're relatively mild strokes. Can you get on the camera and see these patients the next day and the day after, et cetera, et cetera? Our neurologists are no longer coming to the hospital. They're getting older, and our bylaws are not requiring them to take call anymore. So we started to expand what we did as a network. We provided routine, non-urgent consultations and follow-up 7 days a week, 8 to 5. We were now currently contracted at 4 spokes. One of them is a primary stroke center, the other 3 are not. This is kind of how our network is. It really should be 16, not 17, but we have 4 hubs right now in the Houston area that can provide comprehensive stroke center services. We cover 16 hospitals and 7 freestanding ERs. Majority of them are within our own system, Memorial Hermann, and the rest are outside of that system. We're pretty busy, and I think this is just to kind of give an overview of what type of patients we see. A majority of our patients are acute, that we get on the camera for about 40% of the time, 35% of the time. But a lot of our work right now is in that routine consultative population. Pretty busy TPAs, and we've given about 2,300 TPAs over the last 7 years or so. This is, I know I give a lot of talks about, well, what is really needed to provide that rounding? It is very, very different and labor intensive to do that. We now provide 24/7 coverage at 16 hospitals, and then we provide the rounding at 4 hospitals. And depending on the volume, you really need to have enough staff there to do all these things. So we have 1 faculty member Monday through Friday that's on call for all the acutes and on the weekends. And for the routine consultative services, we have 2 or 3 faculty members covered during the week. And on the weekends, we have 2 faculty members that split that work. So you have to have a dedicated system to do all these things, and it gets definitely pretty taxing, and burnout definitely can occur. And why do you need routine teleneurology? The fact of the matter is that it's very difficult for small community hospitals to recruit neurologists right now. It is very financially burdensome for the local neurologists to even go in to see their patients because they have to leave their practice, and they're just no longer doing that. We have one primary stroke center that all of the neurologists refuse to come in, even if it's their own patients, because they don't want to leave their practice. And we essentially are the neurologist in-house via telemedicine. Acute stroke coverage via telemedicine, obviously, a lot of these hospitals, if they didn't have routine neurology coverage subsequent to IVTP administration, their hospitals are not really keen on keeping them because they're afraid of something bad happening if they didn't have that backup. So they were sending us all of their patients. And patients and their families didn't want to travel. They didn't want that. We've had patients refuse TPA because they didn't want to get transferred to Houston, and that was quite scary. I had to talk the gentleman out of that, but it is a very real problem when you're 2-3 hours away, and our stroke patient populations are relatively elderly, and just simple travel for them can become very, very difficult and very burdensome, even financially, to get hotels, parking, and driving. And for the spoke hospitals, it's beneficial for them to keep their patients, especially in those patients that receive lytics, and they get to stay. From the financial perspective, we want to take the patients that really need to come down to us, increase in procedures, complex hospital admissions, and for the spokes, again, they keep that patient there. They get all the downstream revenues, such as rehab, more labs, et cetera. And for the healthcare system, which we try to think about, but it really reduces a whole bunch of unnecessary transfers that nobody really gets reimbursed for. For the patients and families, I talked about that. And for us, it's a service that we provide and get compensated for it, so it definitely provides a level of financial stability. The services that provide and how do we do it? We provide, and there's different modalities of doing this, and I definitely have a preference for the TeleRounding when we actually see the patient every day until all the acute neurological services are done, that all the issues are being addressed. So we get a list of patients that we need to see. We chart round. We have access to EMRs. We have access to PACS. And then after we get the proper information, we get a nurse practitioner or one of the charge nurses to roll us around room to room, and we assess the patient together, drop orders, and talk to our primary medical colleagues about what needs to be done. The other pathway of doing that is there's one-off routine consultations. You see the patient once, you give some recommendations, and you don't really provide follow-up. It's much easier to do, less taxing on the network and the physicians providing that, but I do think that leaves a lot of holes for that patient's care, and specifically for our patients and families as far as education and talking to the neurologist about what acute neurological issues are actually going on. I don't think our medical colleagues can really explain a stroke very well or a prognosis as well as we do. Logistically, very, very difficult to do initially. We've had robots that were lost in the hospital. Nobody knew where they were. And it's definitely a different way of rounding. You know, we're not looking at the chart, seeing one patient and you can hop back and forth. You have to be really strategic about getting these things done, or else, you could take you 3 hours to see, 1 or 2 patients. For it to be really robust and efficient, you have to have a very dedicated staff on your end, remotely, and also the local staff. So a lot of training on the ground, teaching how to call consults, how to move the robot, how to place it by the bed appropriately, how to help our physicians examine the patient, all these things. And I think from the neurologist side, knowing your limitations. So as I said, we're calling it teleneurology. We're not just doing telestroke because, like I said, if they have no neurologist for that seizure patient or patient with brain tumor, they still need a neurologist for to see those patients. So knowing your limitations, what you can do remotely, what diagnostic testing do they have locally, what type of follow-up do they have, and what local resources do they have for that patient. So if they need to be transferred, then transfer that patient. If you need to lay hands on the patient, definitely do that. And knowing the limitations is very, very important. Is there any data for routine teleneurology? Not really. We have some data regarding the drip and ship model in which the patients get TPA and they get shipped to the mothership and compared to patients that got TPA and stayed. The evidence is not very, very clear. Some studies have shown that even though milder stroke patients stay at the spokes, they actually have worse outcomes and high mortality rates compared to the sicker patients that went to the hubs. However, in our data, that was the exact opposite. We were able to show that the drip and ship and the drip and stay were relatively similar in outcomes and length of stay. Is there any data, and this is something that is really key for what we're doing now, is there any data that compares the drip and stay and if that patient is seen by an in-person neurologist versus a teleneurologist that's rounding? There's no data at all. There will be something presented at ISC that one of my colleagues, Dr. Hagelino, is going through that will show that at least length of stay is going to be very similar if a local neurologist were able to pick up that patient and see that patient that we saw in the acute setting as opposed to us picking up versus doing teleneurology. So a lot more research needs to be done. Ways to improve and maintain quality and efficiency. This is for us in a small academic teleneurology network. Building an experienced and dedicated team that, in my opinion, if it's smaller, is a little bit better because we're much more nimble for change. Having an experienced program manager that understands how things work to help resource allocation and things like that is very, very important. All of our, we're kind of inbred at UT Houston. All of the team members have trained there. We all did telemedicine during our fellowship, and those are the people that we were able to recruit. Streamlining and simplifying protocols are important. Simple technology, not to burden the nurses, to pressing buttons, plugging in wires is going to be helpful, and communicating back to referring physicians about what can be done better in real time definitely can be helpful. And continue to reevaluate the goals of the network. So our goals was to do acute telestroke, but that changed when the needs are different. So you definitely need to grow, and strategic and calculated growth. We talked about this all the time. Sometimes, again, that depends on what your goals are. Growing too big just to get market share, if you don't have the resources to back that up, you're really putting patients in jeopardy to getting good quality care. Future directions. So we're doing inpatient teleneurology now. That's been very, very helpful. We're going to be doing more of that because more of our sites are doing that. As I was discussing earlier with one of our colleagues, A lot of networks right now in hospitals that are just participating in acute telestroke or acute teleneurology, they're asking for this service. So if your network is only providing that acute telestroke coverage, your hospitals will be asking you to do this. So be prepared, or else they're going to move on to another set of providers who are willing to do that, because this is definitely a huge demand for this type of business. Future directions for teleneurology, I think it's going to move towards outpatient. We're definitely starting that here at UT Houston, starting the spring of 2020. A lot of simple things like post-stroke follow-up, epilepsy patients, seeing them in their home to reduce travel, following the patients in their community, and including our colleagues in pediatric neurology as well. So, conclusion, I really think telemedicine has transformed acute stroke care. We talked about, seeing the patients in the ER when we were doing it. Now it's in the MSU, and now I think it's going to move beyond that in the in-hospital setting, and also then beyond that in the home. I do think it can be used in certain instances to expand high quality of care in the inpatient and outpatient setting. There's a lot of research that's being done in our group. Hopefully check us out at ISC. A lot of things to talk about that. And I think it is very, very important to educate about telemedicine in our medical school and the residency, even in fellowships, because it is going to be part of how we deliver care in the future. And I do think that the future is relatively bright for teleneurology. With that, this is my group. I want to thank everybody in my group, and that's it.